Um, on that uplifting note, may we then turn to the Chief Executive's report. David.
Thanks, Chairman. I don't plan to go through the report, but there are two or three things I want to talk about. And can I just kind of reinforce the point the Chairman made about Expo, really? I do think it was as a long-standing employee in the NHS, I've been to many conferences over the many years that I've been in the NHS, and this one was different. It felt different. The conversations were different. It was much more patient-focused, much more engaging with people in the general community than I've genuinely ever seen. I think it was a genuinely fantastic event, and it was forward-looking. Given the kind of challenges of the NHS, and we all understand them, and the difficulties that we have, to have the opportunity to think forwards, I think is really important to provide the kind of sense of direction and leadership that's needed. So I think it was a great thing. And part of it, of course, was NHS Change Day. And it's interesting that today is NHS Change Day in Australia. About NHS Change Day, it started off by a group of junior doctors and nurses who really felt that with all the issues around the health service, what were the things that an individual could do, perhaps a very small thing, a pledge that they could make to change their behaviour or the way that they do things, or to try something new on a particular day. Wouldn't that be a good way? And that certainly, it wasn't managed or organised. It grew up from the people who work in our service. And last year we had nearly 200,000 pledges. This year, just over 400,000 pledges. So 400,000 people made the decision that they would do. And I think it's a fantastic. It shows, I think, the kind of passion and inspired and motivated people that we have working out in the healthcare system, and it has expanded now. Last year, people in Scotland and Northern Ireland, because it was fundamentally started as an English NHS thing, started to engage, and now we've got people in lots of countries all over the world starting to think about how they might do it. It seems to be a fantastic story of inspiration and motivation to improve services for patients. And as an aside from that, I made a pledge around bringing together people, users, wheelchair users, carers, charities, people who commission, people who manage the service, bring them together to think about what we can do as an NHS to help and support people in wheelchairs, whether they be young children or older people. And it's an area that I have to say has not always had a great deal of focus on it from an NHS perspective. It hasn't got a medical tribe that looks after it. It hasn't got the kind of power in the system, but fantastically ambitious and motivated people were engaged in all of that. And out of that, I think Ros has, by acclamation, has agreed to become a kind of champion on the board for wheelchair users. There is a lot of people out there who want to work on that, and I think it'd be a fantastic lasting thing that we can do to improve services for people who use wheelchairs. Getting back to the kind of overall report, we continue to do our work on the strategy as it emerges. Quite a lot of it was talked about at Expo, again focusing particularly around those the 6 characteristics about what will make a sustainable and great healthcare system going forward, and I think more of that information will emerge over the next few weeks, and we'll publish some stuff around specialised commissioning and primary care and all the rest of it, to engage people in a conversation to make real changes. I think that's really very good. Part of the conversation we've been having more recently is around the tariff, and I think it's worth explaining. I think what's been happening around the tariff, which at one level is a technical thing, but actually has a significance for the NHS overall. And of course, the tariff is being used to work through many of the plans that people are out there dealing with them at the moment. And there has undoubtedly been some criticism of the way in which the tariff has been set, and I just want to kind of give people the context of all of this as we go forward. And as part of this, I want to talk a bit about mental health services and parity of esteem. the tariff is there's something called the Joint Pricing Executive, which does the technical work around all of this. And of course, the tariff is set jointly between ourselves and Monitor as part of the new arrangements. Now, one of the things that we can do as NHS England, we can put some resource into the tariff that relates to service improvement, things that we think are particularly need funding going forward, and we considered that. And one of the big issues facing, I think, the NHS in the short term is the whole issue around nurse staffing in acute hospitals. And if you think about it, Bruce did his 14 inquiries into hospitals. I think, well regarded and excellent documents that they are, and they kind of pointed out the issues that these individual hospitals had to deal with. In almost every occasion, the issue of nurse staffing was raised as an issue in all of those that needed dealing with. The work that Jane has been doing on nurse staffing, again, would encourage us to believe that most hospitals now are having to look at their nurse staffing. And then you add to that the activities of the Chief Inspector of Hospitals. The pressure on acute hospitals to do something about it, and the nurse staffing was significant. Now, the judgment we had to make in those circumstances is whether you say, well, they'll just have to deal with it through the tariff, or we could make some contribution in the short term to this particular set of issues. And the judgment was made that we would make a contribution to that. We put 150 million into the tariff in relation to the pressures that these organisations were operating. That's not to say that other places in the NHS need support, but the other context of all of this is, of course, in 2015-16, as part of the Better Care Fund that no doubt we'll be talking about later, nearly £2 billion comes out of the acute sector to be used in out-of-hospital care for vulnerable people, mental health service, all this, and that is a ring-fenced budget. So that was the judgment that was taken. The issue, of course, is in those circumstances, and we find this, I guess it's something that NHS England will find quite a lot as we go through, as we identify a priority in a particular area to deal with an issue, a whole load of other people then say, that's not fair, why aren't we being dealt with in that way? And that is a kind of the nature of the business that we are in to an extent. But these are absolutely not seen as a kind of differential approach to many. Absolutely, that was not the way. Right. Which brings me, I think, to the point, the issue of parative esteem generally in the way that we're dealing with this. We've got a responsibility for all of that. It is not only is it a kind of a statement. It is a parative esteem is a value and a principle. It's something about the sentiment, the way in which you think about services, and at an individual level, it's about looking at the whole person. It's about looking at both their mental and physical needs and whatever, but also as broadly about the way we deal with mental health services and deal with physical health services in some kind of organised way. And because people said that the tariff might give a message that in some way mental health services would not be treated reasonably in these circumstances, we've set out some more guidance to CCGs around the planning process to ensure and encourage and support that, the issue about parative esteem, and we've set up a toolkit that they can use to help them work through it. And as an organisation, and that is on the website. People can see that guidance. And as an organisation, we've set up a parative esteem board where we're trying to focus on 5 things that we think are particularly significant to enable us to take this particular agenda forward. The first one is about crisis care. We've signed a concordat around crisis care, something I think that's built very much into the urgent and emergency care arrangements we have. So we want to see improvements in that area. We want to see improvements in the way that we collect and use data and intelligence around mental health. It is, as we know, when we look at the performance reports and all the rest of it, it's not an area that's got huge amounts of data and information available, so getting that absolutely in the right place is as important. As commissioners, we think we need to improve the skills and capability of our commissioning mental health services. It was an issue, I think, for PCTs, and I think it is undoubtedly an issue for some CCG. So how can we promote and develop commissioning skills in the system? We need to focus our attention on the improvement of some clinical services. Undoubtedly, there are services that need improving. Not least of all, we need to think about access to services as part of that, and we need to think about the physical health of people with mental health problems. We've rehearsed before those issues, and those 5 things, I think, are an important first step to making a reality to the sentiment of parity, of parity of esteem. But what we also need to do, I think, is to think about, to build mental health services much better into the way that we're thinking about our strategy. Those 6 characteristics apply equally to mental health services as they do to any other services. So working through that, I think, will be an important part of the board. And I think these things taken together, I think, are a decent first step to making a reality of I think, a value and a sentiment that we would all sign up to. So I think I'll finish there.
Okay, sorry. Thank you very much. May I invite comments, questions from members of the board? Victor.
That's really useful, thanks, David. I think that there was a concern, in fact there was consternation about the tariff arrangements, because it did send out a signal that, unintentionally I know, but it did send out a signal that mental health wasn't, we didn't have parity. And it was associated with the idea that the Francis report didn't apply. And of course what you've just said only goes to prove that if you give something attention, in this case acute services, they also get resources. If you don't give them attention, then they don't. So if you'd actually looked at mental health beds in the same way, you would have had the same calls for resource allocation for staff. So, and in fact, so the question really is, how do we prevent a repeat of the same mess, really, in terms of how we communicated parity of esteem in the tariff going forward? Because I certainly took the brunt of that, because I chair the parity of esteem board. So people, I'm aware that Malcolm has kindly agreed to chair a meeting on Friday with a number of organisations that are concerned with the tariff. But I'm more concerned about how we move forward, and also how do we address the deep concern that there's an historical underfunding of mental health, which the tariff decision exacerbated and underlined. So I'm aware of the Better Care Fund, but that isn't all about mental health, although it's obvious that you don't get better care unless you deal with mental health. But I think it's a watershed moment, really, in the sort of our approach to health and social care generally. So I'd be interested in how we prevent a repeat, because it was difficult, and how we work with the, I was going to say mental health sector, but those people, it's 13%, I think, of our health and social care spend, so it's not insignificant. So how do we build a coalition that builds bridges and gets people to understand that actually mental health is health, it's not separate from? How do we do that going forward?
Before you respond, shall I invite Kieran to come?
I guess the thing I would add, if Victor's talking about the what, there was a bit about the how as well, around the stakeholder engagement, about the impression we given that this had been debated at the board, when of course it hadn't, and just signals matter. So how can we just learn to do the proactive stakeholder engagement rather than the reactive stuff when, for whatever reason, there's a miscommunication?
Okay, David.
Yeah, I mean, all fair points. I think you're absolutely right. I think it is a joint thing between Monitor and NHS England. The issue around the service improvement bit of that. I think if we think about our timetable next year, around making sure that we have a proper discussion about that, because what tends to happen in tariff terms, it happens really quickly at the end as organisations start to, we do the consultation, all that. So I think that's a fair point. So if we need to timetable that discussion properly if we're going to make that decision. I do think though that there is you make a bigger point, Victor, about when you give something attention, resources follow, and when we're thinking about our strategic thinking around all of this, but inevitably, when you prioritise, not everyone's a priority, and so we'll have to handle this sort of thing a lot. But I think the point that that Kieran makes is that our stakeholder engagement wasn't quite up to what it should have been in those circumstances, and hopefully I know you're chairing the meeting on Friday with people about all of this. So as we build up our stakeholder, develop, the way in which we interact with people, I think it'll be better. But I do think this will happen from time to time. I think, people will be dissatisfied with what we do. We just need to manage that sometimes a little bit better.
Well, thank you, David. Barbara?
Just to say that although mental health services are much broader than just those delivered by mental health organisations. Nonetheless, when we look at the CCG and our own direct commissioning plans that are beginning to come in at the moment, one of the things that we will be examining is the commitment to mental health services and the investment in the full breadth of them, as I say, not only in mental health organisations but community services and to support patients with mental health issues when they're in acute trusts. But we're in the very early stages of looking at that at the moment.
Yeah, I mean, the other thing I'd say is that this is a bit about the data business, really, because in a sense, if we measure parity of esteem by how much we spend in specialist mental health trusts, we'll kind of get ourselves into a place which won't necessarily be the. Because if you think about mental health services and people with long-term conditions, or you think about what Geraldine Strathy said to us, I think was it 40% of all people with an injury and mental illness had seen signs of it before the age of 14. These are different kinds of services developed in different kind of ways, but certainly through the planning process, Barbara says, we're really onto this at the moment.
Well, thank you very much. I will chair the meeting tomorrow with a number of mental health stakeholders, with a number of our senior national directors with me, because I think this is a real opportunity to learn from the way both in which this was handled and the substance of the announcement. But also, I would say, don't underestimate the commitment of NHS England to the value of parity of esteem. Operationalising this is hugely complex for all the reasons that Victor and others have mentioned this morning. But if we don't get a grip on it, then it slips further and further from our grasp. So I hope that tomorrow we can take further steps on that front.